Welcome to this lecture called Common Pathologies in the Cardiac Catheterization Laboratory, where we'll have an overview of the common cardiac and cardiovascular pathologies encountered in the cath lab. We'll have a look at how ventriculograms are used to diagnose pathology. We'll have a look at coronary lesions and some other vascular lesions. We'll compare balloon angioplasty with stent deployment. We'll have a look at saphenous vein grafts. We can also have left internal mammary grafts called lemurs. We'll have a look at some valve pathology and specifically examine ischemic cardiomyopathy and compare that with a stress cardiomyopathy called Takotsubo's cardiomyopathy. My name is John Boland. Most of this lecture consists of straight-out AVIs, moving images, so it'll be a change of pace for you after the intensity of some of our preceding lectures. I think it's well deserved, but also you can't get through this term without having a good, thorough overview of what pathologies we encounter in the cath lab and what we do about it. Some we can correct there and then, others we can't. This lecture is intended to cover this missing ground for those of you who haven't spent a lot of time in the cath lab. Indeed, it could take many months, even years, to have a look at all these different disease patterns, and there are many others still to be examined. This is a brief overview to familiarize you with what to expect in the cath lab. We'll start by looking at a normal ventriculogram in a standard RAO view. Hope you can identify that. You can see the backbone is right over to the left, meaning the camera is on the right, and the rib cage swings downwards in its natural arc down to the patient's left. Each clip I'll play 2 or 3 times so you can get a good impression of it. This is all in sinus rhythm. The catheter is across the aortic valve sitting in the left ventricle, and you can see how smoothly and evenly it contracts and how quickly the dye is cleared from the ventricle through the aorta across the aortic valve. That was a normal V-gram. Let's have a look for comparison at a ventriculogram with a few ectopics. No pathology here, a slower rhythm, but you can see how an ectopic or two can make it appear as though there is some kind of a distortion in the ventricle. There isn't. We'll move on. All my slides were intended to replay. This is one I missed. Again, I repeated that previous slide in a different patient, showing you the appearance of ectopics. It can make it look almost like there is an abnormality in the ventricle, but this one, almost every beat is an ectopic beat, not giving the heart a chance to demonstrate its true contractility. We become familiar with these and learn to understand whether there's pathology or not. We'll move on to coronary disease now. This is a coronary artery injection showing you how the origins of the left circumflex and the left anterior descending are almost separate. There's a very, very short stump of a left main. Sometimes they are completely separate origins and we have to inject them independently. The width of the left coronary artery indicates it's likely to be normal, but we would have to do a more selective injection of that to be sure. On the other hand, the injection is selectively into the left circumflex, and if you look closely, you can see a little ostial narrowing that could be better demarcated, but sufficient enough for us to know that that is a lesion that requires treatment. That's how we diagnose coronary artery disease. We look for narrowings and obstructions in flow. It occurs to me this is likely to be a longish lecture because each slide is going to take a little long to play, but I hope you can tolerate it. Indulge me, it's not really a difficult lecture by comparison. This is an example of a saphenous vein graft joining onto a native left coronary artery. It's not a AVI. You can see the sternal clips left in place and the catheter injecting into the coronary artery, and even from this we can see it's a sorry looking artery with multiple diseases. The older the graft gets, the more friable and the more diseased it can become. This is a moving image of that same patient showing you a wire in place with a stent about to be deployed in the distal part. The operator decided to deploy multiple stents in this patient, and we normally start with the distal part to make it easier for the next stent to come down. It would be difficult to cross an already deployed stent. We don't often do it by choice, but it can be done out of necessity. Look at the difference. Each one of these arrows represents a stent deployed starting from the distal disease bed right up to the proximal bed. Sometimes that is the only way to treat these long-standing bypass grafts that have deteriorated with time. And depending on the age of the patient, of course, the amount of surgery he's had in the past, the availability of graft material limits what the surgeons can do. And in this case, he's got what we call a full metal jacket, right down the full length of that saphenous vein graft. I have also seen it in normal vessels from time to time. This is another patient with grafts. You'll become familiar with these sternal clips that remain in place usually for life. This patient has an occluded LAD and proximal intermediate disease. This patient has 3 separations from the left main, a short stump here that branches into the occluded left anterior descending, a branch in between the LAD and the circumflex called the ramus intermediate, or simply intermediate, and the left circumflex with its side branches. You can see it here in 2 slightly different views. Notice the RAO rotation between the left-hand shot and the right-hand shot. In time, you'll become familiar with these orientations. This is an example of an intermediate lesion, the previous case, that is decided to be treated with a stent deployment near the ostium, past that little diseased area that you saw on the previous slide. There is still an occluded LAD, but that would have been bypassed, hence the sternal clips, and the patient's problem was now new disease in that intermediate artery that did not have that narrowing at the time of grafting. We then went ahead to fix this patient quite satisfactorily. This shows you the sequence of steps in the procedure. That's the stent about to be deployed. Very careful positioning to ensure we don't block off the origin of any side branches. This is a different vessel, showing you how we can use a facility called Stent Boost. Different companies have their own proprietary names, but it shows you how we can concentrate the image onto the region of interest and restrict the field of view to the stent area. And that shows us very clearly the extent of area covered by that stent if it were deployed in the coronary artery. This is an example of a totally occluded right coronary artery saphenous vein graft. You can see how it doesn't take much of an injection. The cardiologist can tell it's occluded from his initial test shot, and you can see the reflux moving outwards into the aortic root and no forward flow across that graft. We know it's a saphenous vein graft because of previous observations. So let's go on to look at the effects of pathology caused by coronary artery occlusions. When a coronary artery occludes, unless we rescue it with a stent in time to prevent myocardial damage, we have learnt this leads to infarction. And that is simply a dead lump of tissue, connective tissue, scar tissue, that doesn't have any motion electrically or physically. And you can see here the patient's had an inferior infarct and there's a big lump of tissue causing an amount of pooling of dye in that region. And the contractile portion of the heart is really in the anterior apical region, and even that is not contracting very strongly. You can see how the dye hangs around and is cleared slowly by those ventricular contractions. This, if not already, would lead to a cardiomyopathy. And we'll learn more about the pathologies of different diseases in next year's lectures. At the moment, we're describing the pathology. Deeper understanding will come with understanding the underlying pathological processes. Another inferior infarct. Notice how sluggish the heart is. Again, that lump of dead tissue in the inferior region of the wall. And the rest of the myocardium is doing its best to try to contract and encourage cardiac output. My apologies, another slide that I did not put on repeat. I'll play it one more time. Just appreciate the sluggishness of that ventricle and the immobility, the relative immobility of that inferior wall where the right coronary artery would have suffered the insult, resulting in an infarct, permanent damage to the muscle. A slightly different image is this one. It's a CT with contrast, and the red writing indicates carotid disease. Clearly, it's an angiogram of the head. The angiogram would have been, the dye would have been inserted at the level of the aorta, and the dye would diffuse through all that cranial vasculature. Quick question, can you tell whether the patient is facing us or facing away from us, and what clues would you use? First are anatomical landmarks. That's the aortic arch, and you can see the dense deposits of calcium in different parts throughout the vessels. They're scattered throughout that patient's vasculature, very prominent here at the top of the aortic arch. Anatomically, you have your subclavians coming off on the patient's right side, the innominate, going onto the subclavian, and on the patient's left side, as you would know, it comes directly off the aorta, and the carotids and vertebrals go up into the head. And you can see this very, very tight lesion here in the right carotid artery. So because of that anatomy, the patient is facing us, and this would be the patient's left side. Interesting that normally radiographers tend to put a little letter indicating left or right of the patient, and there it is right here. So that is the patient's right side, so he is facing us, and that we can confirm by looking at the anatomy. Notice how tight that lesion is. Occlusion of that vessel altogether, which wouldn't take much, could result in a stroke, although there is collateral flow around the brain by the circle of Willis. Look at this carotid artery. A very, very tight lesion involving the main trunk of the carotid artery and the bifurcation into the internal and the external carotid. This is a slide showing pre and post stent deployment. And you can see the nice result. You'll also notice that this side branch has been left untreated. Why is this? Well, the way to tell the internal from the external carotid artery apart is that the external has the side branches that go to the jaw, not nearly as critical as the vessels that go in to perfuse the brain. So rather than risk an embolic episode, most cardiologists tend to leave a side branch going to areas like the jaw. And you can see that even though the vessel is not evenly dilated all the way through, this is a special type of stent called a self-expanding nitinol stent, meaning it is not balloon dilated when it's deployed, although it can be post-deployment, but that nitinol material will continue to expand marginally, maybe another 10-20%, and in a few days, that vessel would look probably very even all the way down. The important thing is we have alleviated that tight stenosis at a critical point and restored normal perfusion to the brain, minimizing the risk of a stroke. However, there is always a risk of dislodging an embolic particle that could infarct on the brain. To prevent that, we use what's called a distal protection device, but this slide shows you how that self-expanding stent is deployed. The actual process of deployment takes too long to record on these slides. The memory would be far too intense, but you can see how carefully the device is positioned, comparing this image to a roadmap image that they would have. And here you see that extension, that wire, with a little basket at the end. And that, although you can't see it, would capture any embolic debris that would flow distally to the upper regions of the brain from the carotid trunk. This is another image after the stent has been deployed, showing that little trap, that embolus trap, a distal protection device still in place. And hopefully you can see the outline of the stent along the border of that carotid trunk. And that will continue to expand in time or with time, further assisting cerebral perfusion. Carotid stent post-deployment. Confirming what I've just described. Let's move on now to valve pathology. We're actually making good time, although we are in no particular rush looking at pretty pictures. Valve pathology can consist of either narrowing, a stenosis, or a leakage, a regurgitant valve. And that can occur in the most common valves we look at in the cath lab is the left-sided valves, the aortic valve, and the mitral valve. Although we do sometimes look at the pulmonary valve, and the tricuspid valve is of much less importance, so we tend not to do too much with it, although there are moves to address it more closely. Let's have a look at the moving image. And I've shown you this once or twice before, showing you the patient in nice sinus rhythm. The catheter is in the aorta, and we should not be able to see anything in that ventricle, but you can see that persistent jet from the aorta across a leaking aortic valve into the body of the left ventricle. And the dye is cleared very quickly from the aorta, or the pumping action of the heart. And you can see the coronary arteries on either side of the heart. And this patient has a pacing wire in place as well. Let's have a look at more severe AR. And I should point out these are in the LAO view. Notice also the curvature, the abnormal curvature of the spine. Many of our patients are quite elderly and present with many comorbidities. This is an AVi. Again, the catheter in the aorta, and notice how quickly and completely that ventricle fills. There is almost no restriction to that movement of dye across that aortic valve. Again, another one not on repeat, but you can appreciate the severity of that aortic regurgitation that would be quite restrictive to the patient. And again, out of interest, I would encourage you to read up in anticipation of your lectures next year on the underlying pathology, particularly for the aortic valve and the mitral valve. That'll cover a lot of ground for you in advance. Don't waste your holidays. Many of our patients who have assessments for particularly stenotic valves, not so much leaking aortic valves, go on to have a replacement valve, particularly if they're unsuitable for surgery. This is a rescue for patients who are elderly, infirm, and rejected by surgeons for surgical repair or replacement of a diseased aortic valve. And it's proved so successful in the cath lab that we are now starting to look at possibly doing them in younger patients, although currently the success rate of surgical intervention in younger patients is so great that it would have to be some pretty convincing data to do one of these valve replacements in a healthy 40-year-old in whom a valve has to last the rest of his life, a good 40 years maybe. Whereas in these elderly patients who are well into their 80s, late 80s, they would be grateful simply for another 5 years of life. But the longevity of these valves is still being proven. Let's have a look at the AVi. This is an Edwards valve, which has been crimped onto place with a balloon that's been expanded to sit that ring containing the leaflets comparable to a normal valve to sit at the aortic root, biting into the calcium around that area. Aortic stenosis is normally associated with calcium, and so that is what allows the calcium deposits, the stiffness of that aortic root, to accept that valve ring without being dislodged. Aortic regurgitation is a totally different pathology, and you don't have that tightness around the aortic root that you need to accept a valve replacement. Notice how there is virtually zero aortic regurgitation. In fact, you could say it's zero. And This patient has a new lease in life. Within days, they can get up and walk around without being short of breath. And the plan is to hopefully extend the quality of their lives and their lifespan outside hospital. It is cheaper to undergo this procedure to the healthcare system than to have a patient coming in and out of hospital repeatedly for many days at a time in his later years. This technology is continually advancing, and you will see more of it. It will dominate a big chunk of your studies next year. In the same way that aortic valve replacements have proven very successful, we're now looking at replacing mitral valves. And this is the mitral valve we have used in the cath lab in my unit. And it's much more technically challenging in that it's not deployed percutaneously. It is actually a combination of surgical and percutaneous collaboration that allows deployment of this valve because it is deployed and anchored via a hole punched through the apex. So the anaesthetists have first to anaesthetize the patient, the surgeons then do a mini thoracotomy, make an incision in the apex of the ventricle, and through there, the valve is deployed and anchored around the mitral ring, and then it is actually held in place by little tethers that are anchored to a little strut device, a little prop, a little prosthetic ring or oval that is located at the apex, at the site of that incision that allows the procedure to happen. Difficult to describe in words, too much to include as an AVi here. It would require almost a whole lecture to cover the pathology and the treatment. But just be aware, that's all I'm trying to do, of the different procedures and the different interventions we can do and the massive step forwards we are making in interventional cardiology, actually replacing intracardiac valves from little holes in the periphery. Another procedure we do is to fix holes in hearts, such as a PFO. As you know, a PFO can allow continuity of flow across the chambers, the right atrial and left atrial chambers, increasing the risk of an embolic stroke. A PFO occlusion device, such as this particular one is called an Amplatzer, though I'm not plugging any one particular brand. There are several on the market. You can see one side of that disc fits in the left atrium and the other one in the right atrium. And platelets adhere to the nitinol mesh and eventually lead to re-endothelialization of the entire structure, so you have smooth covering of that pre-existing hole in the heart. Magic stuff. And it stays in place for life. This is another example, but it's for an atrial septal defect, similar in shape. This AVi was far too long to save, but it's a still image showing you how it's done under echo guidance. You can see it's an AP shot, anterior posterior, and the device is a septal closure device, and it is again made of nitinol and is self-expanding. It's deployed across the septum where the hole is, expanded in the left atrial side, and then tugged to ensure it's big enough not to fall through the hole, through the ASD, which has been sized before. And the rest of that sheath is withdrawn, and at the last minute, when they're satisfied that no amount of gentle tugging will release it, it is released and stays in place. Finally, we're coming to the end and we're approaching our cardiomyopathies. You've seen a normal cardiomyopathy caused by an ischemic event, ischemic cardiomyopathy. This is a Takotsubo's cardiomyopathy. May as well play it. It's called a stress cardiomyopathy because it follows a stressful event in a patient's life, most notably women, elderly women, and it causes this characteristic apical ballooning appearance of the ventricle and a lack of contraction or reduced contraction at the base. Many of these patients, most of them go on to recover, although it does have a certain mortality rate in hospital. And the stressful event can be the death of a loved one or some other traumatic event in an elderly woman's life. The coronaries are patent. That's the peculiarity of this condition. And there are a number of theories as to what causes it related to acetylcholine activity and other biochemical interactions. Again, the underlying pathology of many of these conditions is really quite interesting. There is a condition also called reverse takotsubo, where instead of the apical portion of the heart being ballooned, it's a reverse. Easier to see it than to explain it. This is also a takotsubo, but here you can see the apex is contracting, but here you can see the apex is contracting and the base is not. It's a reversal of the previous situation. Coronary arteries were normal, and yet the myocardium still suffered an insult. Happily, a transient insult from which, as I said, many patients go on to recover after a few days of rest and treatment in hospital. And we'll move on. There is a structure in the left atrium called the left atrial appendage that, if you're unfortunate enough to have atrial fibrillation, can cause pooling of blood. That can cause a thrombus to form that, if a small portion even of it dislodges, can go on to give you an infarct, a stroke. So patients who are intolerant of warfarin as treatment for atrial fibrillation, AF, have the option of having this atrial appendage closed so that any spaces of blood inside traps any thrombus formation and minimizes the risk of an embolus and subsequent stroke. That's an angiogram showing the catheter from the inferior vena cava having punched a hole through the septum to access the left atrium. And through this catheter, a little device would be deployed at the mouth of that atrial appendage that would again bite into the walls and trap whatever blood is forming thrombi inside. Another disease condition in the cath lab that we see is a AAA, abdominal aortic aneurysm, dilatation of the aorta anywhere between the aortic root down the proximal part of the descending aorta. And this we can't really correct. It's a matter for the surgeons or the vascular interventionalists. They're another dedicated team of specialists, independent of coronary interventionalists. Again, look at the appearance, totally distorted, and it can affect the valve function. Here you can see it's caused a little bit of AR, and it looks stenosed as well. Calcification of the pericardium. This slide is an AVi, and it shows you the calcific deposit around the edge of the pericardium. Calcific pericarditis. And it would probably, this is part of the investigation in this case, lead to some kind of a constrictive pericarditis. And you can see a Swan-Ganz catheter in the right heart advancing to the wedge position. And finally, our last slide. You can also have a buildup of fluid in the pericardium, and that is diagnosed frequently with echo. I'm sure you'll come across those in your career. But treatment is to insert a needle at the level of the diaphragm into that pericardial cavity and drain the fluid with a very flexible catheter. And as you know, the normal volume is 50. We can often collect in excess of 100, up to 200, even more mils of volume of fluid in that pericardium. That restricts contraction of the ventricle and cardiac output. A life-threatening condition that can be corrected with a relatively simple, straightforward intervention in the cath lab. And with that, I will close this lecture. I hope it's given you an appreciation of the many disease states and make you look forward to the pathologies we will look at and learn more about next year, particularly the TAVIs, a very big dominant force in interventional cardiology at the moment, and it can only continue to go forwards. So with that, I will end this lecture.